Since all the audience were very interested about the MRI breast imaging, so Dr. Abdulhameed Alwabari, he's very kind. He will continue this lecture about the MRI breast imaging. So please, Dr. Abdulhameed, the stage is for you.
Can we? You know, we as a technologist should take care of the patient about his psychological status. You know, patient came to do breast MRI. What do you think? She will be anxious or she will be very relaxed? Anxious. So take your time. Do not make it in hurry. Do not make it like it's only 30 minutes or 25 minutes to finish the exam. She will ask you many questions. Yeah, please, thank you. She will ask many, sorry to say, many foolish questions because she is worried. She is waiting for the result before the exam. So just give her time and give her like 45 minutes as a slot for the exam. Okay. The artifact expected, if the position is not proper, is decoupling. You see here? Because she is not positioning well, she pressed her chest over the coil itself, and that caused decoupling and result in inhomogeneous fat sat. You see, when you just adjust the position, this is the result. It occurs more with heavy patients. So in this situation, even if you adjust the position, you might end up with the same artifact. What you should do? I said the reason just a few seconds ago, that decoupling, because you pressed on the coil. So you put towel, small towel between the chest and the coil. And this is also, you might have it when you have heavy patient, at the side and at the middle. It's gone when you put a towel, when you adjust the patient. Sometimes when you put a patient with improper position, she breathes like, because she's angled, she breathes hard on the coil. When you adjust the position, you distribute the weight over the coil and things will go all right. Okay, when you have inferior bulge, you will have general disturbance of the fat sat. And see, this is the bulge, and there is a line of fat not suppressed around the breast. Right? So what we need to do is just to put the hand and down and recognize it. You know, if you see this appearance to you, you will wonder, what's that? If you don't know the reason, you will not reach to how to correct it. As Dr. Amona said, recognize and organize, fix and finalize. Okay? This is how it is. Now we don't have a fault. And this is the final result. You know, when you look to the images, you might feel that this is unreal. At the end of the talk about this topic, I will put the reference, and you will see all the images on that reference. This one was considered, this was considered cancer. This was diagnosed cancer. But there was a doubt. You know, with the clinical correlation, the patient and the doctor cannot feel it. So they said, how come that it's more to the skin and we cannot feel it? They brought the patient back. Someone did it, good position, no finding. In the article, you will see that this case was diagnosed cancer. And you will read it in the article. And then she has nothing, just position. Challenge with the big breast. There is a solution for this one. We said that we can put towels over the opening of the coil and elevate the patient a little bit, isn't it? Or the cup. But for this one, really, it's annoying. And the solution for it, one of the solutions for it is this fat, they call it fat saturation pad. As we were discussing a while ago, there is a pad for the dielectric effect. There is a pad for fat saturation. This was invented for the brachial plexus. And they were wondering why we don't use it for breast. And they developed it to this pad. Okay, when you put it in the coil, and this is the primary, and this is the result after the pad. Also here, you have inhomogeneous fat sat with the pad. Okay, there is a finding. Lumpectomy and fat sat with the pad. See how it is at the beginning without pad, and this is it. Amazing result, isn't it? Yeah. Let us agree in one point that breast means fat sat. Without fat sat, you have suboptimal exam. So that's why, as I told you in the morning, fat sat was repeated maybe 100 times because it's essential for diagnostic scan. And for the fat sat technique, also, how many fat sat technique we have? 6. Right? Fat sat, spare, stir, water excitation, and Dixon. 6. Why? To use it whenever suitable. They are not suitable for all, and one is not suitable for all. So you have to choose which one is suitable for which exam. So like here, this is fat sat. You can use spare. It's longer scan time, I agree. But this is what you have to produce this diagnostic images. Think of the fat sat technique you have. What's the suitable for the exam? Cartesian and blade. Blade is very popular here in Kuwait. Blade, propeller. Blade, propeller, and multivane and Phillips. Okay, when you do exam with a regular stir, this is the finding. You have good breast, bad axilla because of heartbeat. And this is with blade. Does it work to apply it? Certainly it does. With the blade, you have, now if you have any doubt here, if you are not using a blade and you have doubt in the axilla, what you will do? You are not going to do that technique. You will do it AB. So when you do it AB, you will have this artifact going this way. So this area will be clean. So you are doing 2 sequences instead of 1. Agree? So blade is the solution to suit breast and axilla at the same time. We spoke about this one, and that's the breast. I hope, I present something beneficial. You know the first one? This is the article. See, read the name. Positioning breast MRI imaging to optimize image quality. So I did not invent anything. I just copy the information from the article and I put it in PowerPoint. So if you like, you can go to this article.
So shall we move to the next lecture? It's about MRI parameters trade-off. Also, Dr. Abdulhameed Alwabari, he will talk about it.
You know, trade-off. What you understand from trade-off? Usually, we change a parameter, and we need to adjust the other parameter, which is affected by changing the first parameter, right? I'm not going to talk about this. I know that what you are expecting. I'm not going to talk about this. I will talk about something really it affects what you are looking for, but without going to the routine changes of parameters. So I'm not going to this one, for example, to decrease the scan time. I need to make changes to these parameters, and then I will end up with changes in another parameter. I'm not going to go with what you expect. You know, here, I would like to engross your attention to different angle of how to manipulate the parameters. Why parameters trade-off is needed? To get good image quality, right? So let us start. You know, it's supposed to be the parameter trade-off to good image quality through SNR, through CNR, small scan time, and high resolution, isn't it? Let us see how to achieve one by one. So let us start with SNR. What's SNR? Signal to noise ratio. Signal came from proton, came from the tissue. Noise came from motion or electric noise in the coil, operating the coil. And then we came up with SNR. How AI دكتورة مو موجودة. How AI will improve SNR? Guess. From what you have in the screen. AI. So what does it do? What you have in the system now, and you have AI in the system, it just removes the noise. This is image with a noise, and this is the distribution of signal and noise in the K-space. When we have it with AI, this is the result. Do you believe it? Do you believe it? Because I can prove it to you with a stupid example. My examples are really, I don't know if you like it. This is a light, isn't it? مرمل على ما نقول احنا. Okay? What should I do to make it good? Exactly. That's what I did. That's the noise. So I remove the noise, so I have the same light. I remove the noise, and then I have strong light. I have good SNR. Agree? Did I convince you? Position of the coil. Does position of the coil impact the SNR? You see here? When we put, for example, flex coil in this position, if the shoulder cord is broken, I have this image. If I make it 45 degrees, I have better image. If I have it over the shoulder, I have good image. And if I have it at the side of the shoulder, I have a good image. Why is it? This is purely physics. This is purely physics and could happen in toe. Purely physics. Where we got the signal from transverse or longitudinal? Transverse. So I shouldn't put the coil parallel to this. And, when I put the patient lying down, I'm putting it, I'm lying down in the machine. This is what? This is Z direction, longitudinal. There is no signal in longitudinal. So if you, for example, you are doing toe, and you are using, معلش برفع رجلي, and you are putting the foot this way, right? Okay, and you remove the coil, the cover, and you put a small coil, the ring coil or the loop coil. You get no signal because you are with Z direction. You should put it there or here. But parallel with Z direction will give you 0. And it happened with me. I don't have physics all the time in my mind, and I have done the foot. The signal is bad. I went there, I changed the coil in and out. Nothing. Okay, it came to my mind after several trials, then I remember, okay, it's in Z direction. Okay, so you might have it in the shoulder, you might have it in the foot. The one who's working in Philips will encounter this. Type of coil, an SNR. I will give you, before I open the images, I want to give you an example. Now, if we have twin, one of them is microcephaly, راسه صغير. Should I put him in brain coil? This big, تفاحة راسه تفاحة حطها فيها الكويل. Exactly. I used to put it in knee coil. Unless you have high resolution 36 channel transmitter receiver coil, which is smaller. Okay? So the coil really make difference. So here we have this coil, which show me the pituitary, the cerebellum, and see the high resolution coil, see the cerebellum. You can see the branches of the cerebellum. I did nothing, just I changed the coil. And where I work, we have both. So we always use the high resolution coil unless it's infarct. Infarct doesn't need, to put him in very small coil. You can't put him in the big one, CVA. This is prostate. By the way, this is 18 channel, this is 32 channel. This is 12 channel, this is 32. This is 18 channel, okay? And this is 32 channel. See the prostate. Did I make any change in the parameters? That is a trade-off, but not necessarily with the parameters. Trade-off with the coils. And this is This is the prostate radiologist is looking after. Oh, okay. TR versus SNR. Do we have to get high SNR all the time? Okay. When we have short TR in T1, this is physics, sorry for it, but I know that you don't like physics. This is the result. Because the relaxation is very little. When you give longer TR, the relaxation is better. And this is the image. It's beautiful, isn't it? So high signal means good image quality. Wrong. Here we have longer TR. And this is the result. Bad image. So we should have optimal SNR comparing to CNR. Okay? And TE is responsible for T2. Also, we'll have it the same. You know, I have botagoidance here. The fluid is blue and the fat is orange. So when we have short TE, we have strong magnetization and we have this image. But when we have longer TR, really we have decreased signal of the fat, but we have good image, diagnostic image. And we have longer TE, the fat get more decay, and this is the result, dark, when we need it. Can someone tell me when we need? By the way, what's the value of long TE? When we said TE, as in T1, it's up to 30. And T2, it's up to 140. 140 in flare. So when we said long TE, it's more than 180. Usually we put it 230 in this situation. This is requested by some radiologists for pediatric to see the white-gray matter differentiation. Not this one, but some radiologists would like it to have it darker with 230/80 for the T2, just for your information. Oh, this is. Now we will talk about how to decrease the scan time. How to calculate scan time? TR multiply phase step multiply by NSA over the ETL. This is also physics. I know you don't like it. Okay. What sequence we are calculating the time with this equation? That is TSE. Gradient is different, and 3D is different. So these the main factors that affect scan time. The others, most of the coming steps to decrease the scan time related to TR. Type of RF pulse. We will see, and I think in tomorrow, that RF pulse we have multiple. So when we use fast, that enables me to reduce TR. So we go back and forth, and we are talking about TR. Fat saturation. If you use spare, TR will jump. The same. Slice number also will increase it. RF field of view, no. This is matrix. So it goes back to the same equation. Parallel imaging also is different technique, but it reduces scan time. Oversampling, it does increase TR, and it affects scan time. Imaging technique, either TSE or SE. Like SE, it takes 5 minutes. If you use TSE, it will take 2 minutes. Bandwidth and MTC also enable you to play with the TR. So it all goes back to TR. Sat band, restore, and SAR all will refer you to TR. So TR is the main factor which affects scan time for a sequence. So how ETL, you know ETL, echo train length, the turbo factor. The turbo factor, this is the SE. We have 180, and then we have all this red area as relaxation time. What they did with the TSE, okay? They filled the same area with more 180. Accordingly, I can fill the case base faster and get shorter scan time. You can see it here. You know, we fill it with the number that we are looking for after according to our evaluation. See, from 4 minutes, we goes down to 1 minute. Actually, this is the type of RF pulse. We have this one, which is LUSAR. LUSAR echo spacing is 19, as you can see. So between pulse and pulse, there is a time. So that time is quite long, LUSAR, because you need to separate them to reduce the SAR, reduce the thermal effect on the patient. When you have normal, you see the echo spacing become higher, becomes the echo spacing, this one, smaller, so I can reduce the TR. And see, when I have it here, I have here fast pulse. See, it becomes smaller. The echo spacing, accordingly, I can reduce the TR. Also, from the technique to reduce TR is to choose the right technique. Like this one is fat sat, and this one is fat sat, but see the time. So, as I told you, why should I go to spare while I can do it with spare rather than spare? So the technique also can help you to reduce the scan time, to choose the right technique. And also to choose the right sequence technique. You know, SE, as I told you, is the longest. TSE will reduce the scan time. Gradient is short. And steady state. Do you have an idea about steady state? Steady state is the sequence that you don't wait for relaxation. You just give pulse. And it's very fast. It's applied in IAC. Parallel imaging. You know what's parallel imaging? Usually we have this coil, and we have the case base filled this way. So we have one coil, and we get a signal, and we will fill case base with this signal. And we get this image. In parallel imaging, the same coil, which is one, divided to two. So I have two coils. And each coil has a wire taking the signal to case base. So case base fill two lines together. You will see it here in the next. In cardiac imaging, they use 4 accelerating factors. So you divide the coil to 4 portions. Each portion get a signal and fill case base. So instead, let us assume that each line need 1 second to fill the line. Okay, so you need 4 seconds. But with the parallel imaging, 4 lines with 1 second. That's the parallel imaging. Okay, and you get the image as you see. You see, this is the first line because the coil is covering only the upper portion. See how it is? And this is the second line. This is the third line and the fourth. This is how the image is acquired in parallel imaging technique. And then merge it and get this image. However, because the images need to be tailored, تخيط مع بعض, we will have artifact and we'll have decrease of signal. The artifact is aliasing and we deal with it. Agree? We are all apply parallel imaging, especially with cardiac. You cannot do cardiac without parallel imaging. Actually, it's a preset. Okay. The last parameter that we will consider as a factor for good image quality is CNR, which is contrast to noise ratio. And that we will do some work with the parameters, with the real parameters. So magnetization transfer, MTC. What we use MTC for? When MTC is a preset in MRA. Go to your sequences, you will see in MRA, it's sit there. So when you yourself turn it on, huh? Tell me the disease. Yes, an MS, an MS. You know, subtle enhancement, we'd like to see it. You can see here the enhancement, you know, between this one and when we apply MTC. And you can see, it looks like something here, but here there is nothing. But after MTC, there is something. So this is how you try to enhance the contrast to noise ratio or the contrast of the image. Saturation band technique for MRA. Okay, this is MRA, bland, right? Agree? So what's the function of this one? The function of this one to suppress veins, right? Okay. Why we have it in portions? So we have the saturation band, change the contrast because it suppressed veins. So that's the first. And this is the image that we will see without veins. Okay. But why multi-stack? Why we just do it in one stack? Okay, let us assume that now radiologists ask you to do more coverage. You will add stack or you will add slices. So let us assume this stack, this portion is 40 images. Can you make it 45? Can you make it 50? Or you will add new stack? Let us assume the lesion is here and the radiologist would want to cover this area. Do not increase the slices. If you increase the slices, you will get saturation. معلش عندي مثال بس هذا. I have example to make you understand this. You know that the spin, the proton, shouldn't expose too many excitation. That will suppress it. So I will give you an example if you have your kid and you want him to understand the explanation for tomorrow subject, you will hit him one time, isn't it? If you keep hit him, is he going to understand? He will not. So it's the same here. You have proton. You need a signal from that one. You hit him with the RF pulses, the time required. If you increase the distance, if you increase the slices, you increase the distance. So the excitation with the pulses will be more. And that will make, at the end of the vessels, fading. So whenever you need to increase the coverage for MRA, don't increase the slices. Increase stuck. It's 4, make it 5. And if it is more than, okay, make them less. Instead of 40, make them 35. And that will make you not to waste more time in unneeded area. But do not increase slices. Saturation band and MRV. We put it here. Why we put it here? At the inferior. And the MRA we put it superior, right? So why we put it inferior? To suppress artery. And we got only veins, right? Okay. Why we make it angled? The same reason. You know here, if you make it straight, okay, what you will do, you will expose the protons of flowing blood to too many excitation, and that also will suppress it, and you will get fading sagittal sinus appearance. So you have to, it's not optional, you have to angle it. If you are not angling the planning, you don't produce a good one. And by the way, see here, just watch this. The angle this way, and axial the other direction. To maximize that, you have a fresh blood, coming and exciting fresh blood. Try it tomorrow. Thank you.